Good morning. If I could get everyone's attention, I think we're ready to get started. Good morning and welcome to the Baker Institute for the 2022 Texas Vaccine Symposium. I'm Rula El-Siraj and the director of Baker Institute's Center for Health and Biosciences. The Center for Health and Biosciences seeks to advance evidence-based policies and decision-making to promote health and well-being in the United States and around the world. Our portfolio includes U.S. healthcare costs associated with medical care, childhood health policies, especially social determinants of health, emerging biochemical technologies and ethical and policy challenges associated with them, firearm injury safety and prevention, maternal health and mortality, and the topic of today's lecture, vaccine policy. Today's event is a series of two panel discussions highlighting recently published research from the Baker Institute on vaccine policy issues, including vaccine equity, hesitancy, and economics, as well as future challenges for vaccine policy and the impact of claiming vaccine status as a protected class. In addition, we will end the symposium with a discussion between Rice University's Dean of Weiss School of Natural Sciences, Tom Killian, and Dr. Peter Hotez, the Baker Institute Fellow in Disease and Poverty and Dean for the National School of Tropical Medicine at Baylor College of Medicine. Today's event is a collaboration between the Baker Institute's Center for Health and Biosciences and the Immunization Partnership and part of Baker Institute Vaccine Project. The Vaccine Project is led by Dr. Kirsten Matthews and Rekha Lakshman and Dr. Peter Hotez. They explore issues related to vaccine misinformation, hesitancy, and public health. This morning, I'm happy to announce that the project received a grant from the Greenwall Foundation in their Bridging Bioethics Research and Policy Program to disseminate work from this symposium during the 2023 Texas State Legislative Session next spring to help promote vaccine policy and improving immunization rates in Texas. So be on the lookout for more work in the future from this group. Finally, before we begin our program, I would also like to thank Dr. Kirsten Matthews and Rekha Lakshman for organizing today's event. In addition, I want to thank the wonderful Baker Institute Event Communication and Center for Health and Biosciences staff, especially Jackie Klotz and Caitlin May, for their support organizing today's event. Finally, I would be remiss if I didn't acknowledge our collaborators, the Immunization Partnership, or TIP, as they are known. Giving us an introduction to the work of TIP is Ms. Terry Burke. Ms. Burke is Executive Director of TIP. Before joining TIP, Ms. Burke served for 13 years as Executive Director of the ACLU of Texas, leading the charge to defend and preserve the individual rights and liberties guaranteed to every person in this country by the Constitution and laws of the United States. This has become increasingly relevant in the conversation on vaccine policy. Today, Ms. Burke supports political advocacy, long-lasting partnerships, and the establishment of grassroots operations in favor of immunization best practices at the Immunization Partnership. Welcome, Ms. Burke.
Good morning. Thank you, Rula. It's wonderful to be here. We're delighted to be part of this event and or help to organize it. The Immunization Partnership crew, with our close here, is excited to show you our close collaboration with the Baker Institute. We feel like this is a way to put it on full display today. This 4-year-old partnership was one of the first things I learned about when I joined TIP late last year. The two organizations, the first with a legacy as one of the nation's premier policy think tanks, the other esteemed for its expertise with immunization issues and success in passing pro-vaccine public policy, came together to identify policy solutions and recommendations to improve access to vaccines and to achieve higher immunization rates. Think about when this partnership was formed 4 years ago. A good 2 years before COVID became the first word some children learned to speak. The tribe of vaccine hesitant, even vaccine denying people, particularly parents, was already looming over our health discussions. TIP had been tilling the fields for a good 10 years at that point, advocating among regulators for enhanced health practices, such as a statewide immunization registry, educating the public, and most particularly those working in healthcare, about the improved health outcomes for those who had been vaccinated, and educating lawmakers about the ways strong vaccination policies could protect their communities and thus their constituents. Then vaccines suddenly became one of the most political words in our discourse. And now, in so many ways, everything in our lives has changed, from the places where we work to how our children are learning to how we congregate. And all the anti-safety rhetoric surrounding the COVID vaccines has bled over into our discussions about other vaccines, those with the longest history of doing their jobs, preventing more than 20 life-threatening diseases. Diseases, I might add, that have not gone away. The number of people receiving routine vaccinations, though, has dropped for the first time in a decade, putting our children and our communities at greater risk for disease outbreaks, such as measles and chickenpox, and God forbid, polio. For those of us at the Immunization Partnership facing a public with a greater mistrust of government and a fear of outsiders, change means being more assertive and more aggressive, including taking our expertise to the public, thinking and researching more about how to talk about vaccinations, enlisting a corps of vaccine champions so that our advocacy can be heard across the state. We are still the voice for Texans who want to prevent disease, and we believe the majority of Texans understand that one of the easiest, surest ways to do that is through increasing our vaccination rates. Leveraging TIP and Baker's collective knowledge and unmatched expertise has made us one of the most effective voices for strong vaccine policies at the Texas legislature. And now we are showing others they too can use their voices. FDA Commissioner Robert Califf was in Houston this past week, speaking to students at the McGovern School of Medicine. I thought his message spoke precisely to how we see our role in the near term and in the future. He said, we need the average clinician and public health person out there talking it up and having personal interactions with people to overcome the suspicions that they have, which are fueled by the misinformation effort. It's not just about vaccination, he said. We need a resurgence of the clinical and knowledge-based community. That's what we're doing at TIP. We're teaching everybody, from community health workers to private practicing physicians, how to use their knowledge and public esteem to not only ensure better health outcomes for their patients, but to inspire those same patients to speak up and speak out at school boards and city council meetings, county commission meetings, to visit with their state lawmakers in their in-district offices. In short, ensure that our voices are as strong as our numbers. In other words, be louder than the anti-safety minority. At the same time, we know the need for good, nonpartisan vaccine policy research is more critical now than ever. The Vaccine Project, this initiative formed between Baker and TIP, needs the depth of policy experience from both groups, and TIP's team's ability to translate those recommendations into legislative advocacy and action. There is really no one else in Texas that combines this kind of expertise of these two organizations, which is why I joined Rula in celebrating the Greenwell Foundation's gift to our joint initiative. And let me add that continuing funding for this work in Texas serves the entire country, because for both good and bad, the future of our nation runs through the Lone Star State. Today, I think you'll get more than a taste of how lucky we are to have this group of thinkers and advocates working to make our state the kind of leader in which we can be quite proud. Thank you.
Thank you, Terry. To start our program, I'd like to introduce Dr. Hena El-Sahli, who will be moderating our first panel titled Texas Vaccine Policy Concerns. Dr. El-Sahli is a professor of molecular virology and microbiology and of medicine in the infectious disease division at Baylor College of Medicine in Houston, Texas. In 2021, she received the Michael E. DeBakey Excellence in Research Award, which recognizes scientists whose recent research demonstrates the breadth and the depth of basic science at Baylor College of Medicine. Since 2016, she's served as the principal investigator at Baylor's National Institute of Health-funded Vaccine Treatment and Evaluation Unit, where she and her team conduct translational research on vaccine candidates including flu, neglected infectious diseases, and agents that could be used as bioweapons. She is co-principal investigator and co-author of the study that first established the efficacy of the Moderna vaccine to prevent COVID-19, leading to its emergency authorization for use. I think that deserves an applause. We all owe her some thanks for that. Her work on this vaccine significantly impacted national and global health policy, saving the lives of millions around the world. She is an international leader in translational research for vaccine development, and her work has been recognized and with appointments to the World Health Organization, National Institutes of Health, the U.S. Food and Drug Administration, and the Wellcomes Trust scientific advisory panels and boards. Welcome, Dr. El-Sahli.
Thank you so much, Dr. El-Sahli. Good morning and welcome, everyone. Our first panel will explore Texas vaccine policy concerns, a series of presentations from our experts on the current landscape of vaccine policy in the state of Texas, as well as concerns related to equity, economics, and anti-vaccine rhetoric. The session is organized in 3 15-minute presentations, followed by a 30-minute session for questions. I'll try to keep the presenters on time so we have enough time for the discussion part. If you have any questions, please use the QR code found on the back of your agenda. The QR code on the right will take you to an online Google form where you can submit questions to the panel. If you want to direct the question to a particular speaker, just write their name at the beginning of the question. You can use the QR code and the Google form multiple times throughout the day and the session, and we do encourage that. The QR code found on the left will take you to the agenda and links to the presentations and the papers. So to start this morning, we will hear a presentation from Dr. Kirsten Matthews. Dr. Matthews is the Fellow in Science and Technology Policy at the Baker Institute for Public Policy. She leads both the Science and Technology Policy Program and the Biomedical Research Program in the Center for Health and Biosciences. Dr. Matthews has a PhD in molecular biology, and she transitioned to public policy shortly after her degree to bridge the gap between science and society. Her research focuses on ethical and policy issues at the intersection between traditional biomedical research and public policy. She explores the regulatory and ethical issues associated with emerging biotechnology, including vaccines, stem cells, synthetic biology, and genomic medicine. In addition, she leads a project to understand how science advice on the White House Office of Science and Technology Policy and the President's Council of Advisors in Science and Technology with Dr. Neil Lane and Dr. Kenny Evans. Their work has led to the creation of the first archive of OSTP and PCAST materials spanning 5 administrations. Related to vaccines, Dr. Matthews and her research teams focused on understanding state and vaccine politics, the impact of anti-vaccine advocates at the state level, and rhetoric used by anti-vaccine advocates. She previously studied anti-vaccine rhetoric during 2 highly contentious 5+ hour hearings in 2017 and worked with Dr. Rekha Lakshmanan, who will be presenting in the second panel, analyzing vaccine-related bills filed and passed over 10 years from 2009 to 2019, highlighting how vaccine policy can be bipartisan. Dr. Matthews will be presenting on her research that looked at anti-vaccine rhetoric during the 2021 Texas State Legislative Session. Please help me welcome Dr. Matthews.
Well, hello, and thank you so much, Dr. Elsera. That was a really lengthy introduction, but very flattering. And I'm really excited to see so many people here today. It always makes me nervous when we do these events that no one's going to show up, and I'm just going to speak to the moderator. But I like the fact that we have so many who showed up and were really interested in this topic, as well as Reka and myself. So how I decided to do this is I thought I would set the stage, I think, for the rest of the presentations today. I'm going to really discuss arguments related to vaccine resistance and hesitancy during the 2021 Texas legislative session. I could just click. There we go. So if you're not as familiar with the Texas Ledge like I am and Reka are now, just to give you a little background, we meet every other year on odd years, and they are required by the Constitution to meet for only 140 days. So that usually starts in kind of mid-January and leads all the way through May. In 2021, in addition to those 140 days, there was 3 special sessions, each 30 days long, that was called by the governor. Those were quite, I would say, contentious issues all the way through, but they're only required to actually patch a budget. In addition, there was several sessions that were focused on other things, including things in response to the pandemic, as well as vaccine during one of the legislative sessions. In total, from all the regular and 3 special sessions, over 7,800 bills were filed, and over 100 of them we noted were related to vaccines or immunizations in a broader sense. This time I didn't really want to look at every bill that was filed. I really wanted to focus in on ones that got hearing because I was actually really curious about what was going on. So what we're interested in specifically are what are the types of arguments anti-vaccine advocates are promoting, what kind of evidence do they use, and how do they define and describe the concept called medical freedom. So I'm not going to talk about that now, but I'll talk about that a little bit later in the presentation of what I mean by medical freedom. Other people have asked me why we care about what this group is saying, but misbelief, I think, and misinformation tends to promote. If you hear it enough, it actually increases and turns into kind of a misbelief, an idea that there is maybe some kernel of truth within something that you've heard quite frequently that's being passed around either in person in your friend group or online in social media. And that will likely ultimately lead into hesitancy, including hesitancy about or resistance for vaccines. We do know there was a decrease in vaccinations during the pandemic. I believe the majority of that was related to access, but we're still a little concerned that there also may be a growing hesitation and resistance that's also causing this. So back to the project. What we decided to do, again, was to survey all the bills that were filed. As I said, over 7,800 bills. We specifically looked for ones that mentioned the word vaccine, which we again covered 83 bills, and then focused on those that got hearings. From those, then we also looked at what kind of bills they were specifically, the content of it. So some of these bills maybe reference a section of a law that actually is related to vaccines and it has no direct implications to vaccines. Some of them were for animal vaccines, and that's not really our topic here today. Then we also sub-focused into 2 issues that we were mostly interested in, which were ones that were related to mandates, so vaccine mandates, and ones that were related to transparency. So in the end, we narrowed ourselves down to 5 hearings. So here's a list of all the 5 bills that we pulled. As you can see, the reference R is going to be the ones in the regular session, and the reference S3 are the 2 bills that were during this 3rd special session. So the first 2 are kind of highlighted in a blue color. Those are related to transparency. So one wanted to identify immunization rates at a school level. In Texas, we identify at a district level, and we're all based here in person in Houston. So you all know HISD, and you know it's huge. It's one of the largest school districts in the country. So data that we collect from Houston Independent School District has absolutely no relevance to the school my child is going to, the elementary, middle, or high school level, right? Because we're looking at it as a totality of hundreds of thousands of children. The second bill was to add an informed consent process to vaccinations, all vaccinations, because they saw that there was an informed consent for the unapproved one that were under emergency use authorization. So they thought this would be a great idea. So every time you went to the doctor's office and you got your child 3 shots, then you had to walk through a form that was 10, 12 pages long in order to get the vaccine. There were 3 other bills that were related to mandates. The first one would prohibit vaccine status discrimination, period. So that covers everything, which in effect would actually remove any school mandates, for instance, any kind of mandate whatsoever. And then the 2 bills from the special sessions. The second one would just require COVID vaccine exemptions, and then the first one, not only would it require exemptions, but it would also prohibit mandates, as well as vaccine status discrimination. In total, we had 15 hours of testimony. There were 153 witnesses for these 5 bills. Each hearing, we transcribed, we read it, we coded it first to determine what kind of witness they were. They identified themselves publicly, saying either they're for or against a bill, but also by reading the transcript, you could see that as well. So we could identify those who were neutral, who were for vaccines, and who were against it. Focusing in on those who were against it, we ended up having 84 statements by anti-vaxxers. And I wanted to remind everyone that these 84 ranged from people who were against all vaccines and some of them who were just against the COVID-19 vaccine in particular. So briefly, and I'm going to walk through these each in more detail, we found 3 major themes, one of them which I hinted about before, medical freedom. We see that quite a bit, and I think you might already be familiar with that overall with mandates, as we saw during the pandemic. We also heard a lot of discussion about discrimination, and then we also heard a lot of references to science. And that's one that's particularly interesting because in the past we actually heard more of harms, more of things that vaccines cause X, Y, or Z. This time we saw them try to dig into the scientific literature to justify a little bit more their anti-vax status. So medical freedom, how we define this is an individual's right or freedom to make medical decisions for themselves and their children. So overall, this seems kind of a benign statement. Of course, you want to make your own rights. But what's embedded within this is actually kind of pitting it against a public health versus a individual health. So you're making a decision that affects your neighbors and everyone at your particular table by choosing not to have a vaccine, or in your particular school by choosing not to have a vaccine. We saw that in a lot of the statements, they talked about things, not necessarily using the term medical freedom, a few people did, but most didn't. They caged it mostly in rights. They talked about bodily autonomy quite frequently, which I think is kind of interesting because it was language that they pulled from the pro-choice movement. We saw them talk about these rights, and then they also went a step further is they embedded these rights within the US Constitutions, as well as something that made them special as Texans that we noticed quite frequently. As Texans, we have this particular right. Like Texans have an additional right not to follow mandates. Some even moved to Texas to avoid mandates in other states, they stated. Others referenced other people moving. They often use kind of loud and I would say bombastic language. And I'm going to pull a quote for you for one of them in particular. So this individual testified for SB 51 during the 3rd special session, which again bans vaccine mandates, discriminations, et cetera, and requires exemptions for COVID-19. So this individual said, this issue probably, where Texans are probably going to turn the tide against the rising tide of global tyranny. We hope you will honor your oath to the Constitution. You will do what the framers of the Declaration did, which is pledge their lives, their fortunes, their sacred honor to secure your unalienable rights from tyrants. And remember, this is talking about whether or not we should actually get a vaccine and whether or not we should ask somebody in going to a specific school or a specific job to actually get a vaccine. It does seem kind of a bit on the extreme in comparing those people interested in public health to dictators. We also saw a lot of discussion of discrimination. These witnesses described bullying. It was either themselves or others they saw bullied, or hypothetical, we could get bullied. We saw a lot of discussion about job loss. Some people described losing their job because they didn't get the vaccine. Others got warnings that they could lose their job without it. In addition, we saw them discuss restrictions and limitations to access. They talked about not being able to go to restaurants, some limited access to schools, and my personal favorite was the one who complained who could not go on her European vacation because they required a vaccine. The witnesses also mentioned specific by name, Houston's Methodist Hospital. If you recall, in the spring of 2021, they actually passed a mandate for all employees to get the vaccine. And again, Dell Computers, because apparently they had sent a notice out the week of one of the special sessions. Exemptions were also discussed. A few witnesses described medical exemptions that weren't upheld. So I think that is something we should be concerned about if we do have these. We've always been open to medical exceptions. There are actually legitimate medical reasons you shouldn't get a particular vaccine if you have an allergy. But in addition, there was a lot of discussion about why natural immunity should also count as an exemption. I got COVID 3 times, so therefore I shouldn't have the vaccine. Although, if you got it 3 times, maybe you weren't immune if you keep getting it over and over. And then philosophical and reasons of conscience was also discussed. I just really don't want to get it. So here's an example quote from one of the individuals who testified. So this was during the regular session where they would have prohibited vaccine status discrimination. The individual said, "Through the votes on this bill, the committee will either advance Texas as a state that protects the liberty of its citizens, or it will oversee the creation of a permanent class of second-class citizens in Texas, the unvaccinated." So this both promotes an argument about discrimination with the second-class citizenship, but also makes references to the medical freedom idea we were discussing previously. In addition, we also heard them talk about science quite a bit within the testimony. They would actually talk about specific scientists. They mentioned Dr. Fauci a couple times. They mentioned a particular Yale scientist named Harvey Risch that I wasn't familiar with, nor am I familiar with his work. They mentioned agencies like the CDC and the National Institutes of Health. They love to talk about the data from VAERS, which is the Vaccine Adverse Events Reporting System. A lot of them use this as a justification that there was a harm with the vaccine, so therefore it shouldn't be mandated. Others oddly used it as a suggestion that there's more harms that are out there because it doesn't report things effectively. But when you actually read the VAERS site, it actually says the opposite, which is they do not go through and ensure and pull out some of the things that are in there that aren't related to the vaccine. So it's a little complicated. We also noticed they mentioned research, specific research studies. And then I also wanted to bring up, there's a lot of discussion of, and like a comment that would be framed as, I'm not anti-vaccine, I'm just. So I'm not anti-vaccines, I'm just against the COVID vaccine was quite common. But others were like, I'm not anti-vaccines, I'm just for releasing more data and informed consent, or against releasing data, such as your immunization data. Or I'm for promoting more research on vaccines, just in total to make sure that they're actually safe. Again, an example, this individual pulled up a study, and the reason I pulled this one in particular is because we followed through and actually located the specific study they were referring to, which isn't actually completely common. Most of them were just broad and vague enough we couldn't identify. But this one in particular mentions Oxford University finished a STOIC, which is called a steroids in COVID trial. They found 90% of emergency care visits would be prevented, according to Oxford University, the oldest university in the English-speaking world since 1096, with 72 Nobel laureates. They're a reliable source of information. I would totally agree with that. Oxford University does have really good research. They do have lots of Nobel laureates. We hunted down this particular paper. It was actually published in a Lancet journal. It was a phase 2 trial. So if you're familiar with phase trials, this was a small cohort trial. In addition, it only helps you if you only have mild to no symptoms. So these are actually very useful, and I think they're actually being used right now still, to individuals that we think are high risk and have mild symptoms in order to keep them from being hospitalized. This does not justify never getting a vaccine. Those people are still at high risk as well. and kind of over-exaggerates the 90% kind of over-exaggerates the claim of exactly how many hospitalizations would actually be necessary. Another thing we found was the number of people that came over and over to the hearings, which was actually kind of fascinating. So we actually coded those a little bit separately. So some of them, we have codes they're based off of different cities in Texas, and these ones that had R's in front of them is the ones that they repeated often. We saw for the people who identified for pro, who came multiple times, we had 2 of them, we had 10 of them that went to 2 hearings, and those were usually either 2 regular session or 2 special session 3 hearings. But we had 8 people who were anti, with 4 of them who came to almost all the hearings and 1 who came to every single hearing. We now know her name. I asked Reka, she identified her too without actually even seeing it. We're quite familiar. And then these 8 individuals particularly have very similar language, and they're all part of the same anti-vaccine group. You can look them up, which I'm not going to name names right now, but you can look them up online and you'll see all the faces in there as like the leadership for it that came like 4 out of 5 hearings. Remember, these were separated by time over 6 months. The regular session most of the hearings were in April, and that 3rd special session was in October. So they were very active and engaged. We were also kind of curious in how they dealt with, and we looked at specifically the 2 transparency bills and how they reacted to 2 things that were talking about transparency. So this one in particular, when we looked into requiring informed consent, so this would be a lot of paperwork whenever you asked to get a vaccine for your child. They said, an individual has a right to analyze all the risks and benefits of a proposed medical intervention. But in contrast, for the second bill that we were looking at, which was releasing school-level data, she's like, data provided a false sense of security and would not actually help parents make sound medical decisions for their children. So it's like, it just depends on what you're looking for, how much they feel about informed consent. And I think we have an expert in informed consent up here, and she's like, what? So I'm going to just wrap this up of what we learned, I think, during the session overall. Anti-vaccine messaging, I think, was very, very visible and prolific during the pandemic. Advocates that used these language of medical freedom, rights, discrimination quite frequently in order to kind of pull themselves forward and to promote these anti-vaccine legislation. They were very mobilized, we saw, and they really try to promote themselves as, even though they're a small group that comes repeatedly, as a voice for all Texans and Americans, which I don't think is quite accurate. And before I leave the stage, it takes a village, so I need to thank lots of people up here. Obviously, Reka and the Immunization Partnership, as well as my colleagues at Rice University and the Baker Institute. We had a staff of students who also, bless their hearts, went through all the testimony to be able to help identify everything. And then our fabulous research staff, that includes Jackie Klotz and Caitlin May, who helped quite a bit. And then finally, I really have to thank the Greenwell Foundation for seeing our work and giving us funding to help distribute and disseminate this during the special session. Thank you.
Thank you, Dr. Matthews. Our second presenter this morning is Mr. Adam Navarra. Adam Navarra is a PhD candidate for the Rice University Department of Bioengineering in Houston, Texas. Working in Dr. Tony Miko's lab, his research involves developing bioinks to 3D printing of bone and cartilage tissues. In addition to his graduate studies, Mr. Navarra is active in public policy. He was an intern in the Baker Institute developing civic scientist leaders program in 2020, where he and a cohort of Rice Science and Engineering graduate students were trained in public policy and helped raise awareness with policymakers of the importance of funding basic research. He and several colleagues from the program created the Rice Science Policy Network in the summer of 2020 to bring together Rice graduate and undergraduate students interested in science policy and public engagement, which he served as president last year. He also was a Texas Science Policy Fellow in 2021, where he worked with the Immunization Partnership to research vaccine bills filed and provide relevant vaccine data to Texas legislators. His work during the session led to the policy brief by other Texas Science Policy Fellows, published last spring, titled Failures in COVID-19 Vaccine Administration Data Collection, Complicated Efforts to Ensure Vaccine Equity in Texas, and is the basis for Navarra's talk this morning. Please welcome Mr. Navarra.
Good morning. Thank you very much for that kind introduction. As Dr. El-Sali mentioned, my name is Adam Navarra, and today I'll be talking about COVID vaccine equity in Texas. And I want to just point out that this was a collaborative effort between Baker's Science and Technology Policy Wing, the Immunization Partnership, and the Texas Academy of Medicine, Engineering, Science, and Technology, as well as funding from the Colleges of Engineering and Natural Sciences here at Rice. There we go. Okay. And as Dr. El-Sali mentioned, I'm a bioengineering PhD student here at Rice. I'm in my 6th year, so almost done. Working on my dissertation as we speak. But I was also a Texas Science Policy Fellow in spring 2021, so last legislative cycle, about a year and a half ago now. As mentioned, we worked with the Immunization Partnership to monitor vaccine-related bills during the legislative session. And this ended up, whoa, slides are a little off. And this ended up being published as a policy brief that, if you're interested in, is still up on the Baker Institute website. So I'm going to talk about it today, but if you want to read it for yourself, it's available. So our motivation for looking at the equity of the COVID-19 vaccine distribution in Texas was that, it's well documented that the COVID-19 vaccine has significant health outcomes on individuals who may come down with COVID. And so unvaccinated individuals are 13 times more likely to be hospitalized and 6 times more likely to die during that initial rollout stage. So that was kind of the original COVID variant, the Alpha variant, as well as those original Moderna and Pfizer vaccines that were coming out. We looked at a few factors, but we kind of zeroed in on race. Race was one factor that has historically been attributed to affecting your access to healthcare, as well as age, geographic location, and your disability status. But in particular, we zeroed in on race because the Department of State Health Services had to actually issue a clarifying order to vaccine providers to ensure that the race of recipients was recorded, because during an initial rollout period, it was not. And so what we actually found, yeah, that's a bummer. But what we actually found was that during the beginning of the rollout, so December to February 3rd, when they issued that clarifying order, 50% of records were missing the race data for the recipients. So about 2 million vaccines have been distributed during this time. So about 1 million vaccines, it was not clear what the race of the recipient was. And so that complicates efforts to ensure that all members of Texas are getting equitable access to the vaccine. By April 23rd, so that's 28 days after the vaccine was made available to all adults in Texas, counties had on average 16.4% of patient data still missing that race information. This was significantly higher in rural counties, which had about 17% missing the race data, compared to urban counties, which had about 14% still missing. And as you can kind of see here in this graph here on the right, several rural counties actually had upwards of 40 to 50% of their patient data missing the race. And in particular, we talked about geographic location also being an issue, rural versus urban. You kind of have a bit of intersection as well. And so we're trying to having those rural counties data and making sure that rural populations of Black and Hispanic Texans are receiving those vaccines is very important. And so that missing data in the rural counties was very worrisome. So some possible explanations. As I mentioned, there were delayed data requirements. It was about a 1 month period before it was mandated that if you were giving out a vaccine, you need to be recording the race of the recipient. And in particular, if patients are receiving those vaccines early on, whether that has any sort of racial trends as well, that's going to be missed by not having that data collected. And there are also several issues in data collection from frontline workers, which was noted in the press as this was happening. So what ended up happening was that in order to track the vaccine distribution and allocation, the Department of State Health Services, DSHS, had to co-opt the immunization registry in Texas, so MTRAC2. So all states have an immunization registry. It's how they keep track of the public health data related to immunizations. But Texas is one of the only states where the immunization registry is largely opt-in, and so the patients can only get tracked if they say, we want you to track us. And so it's really not a very large system because most people just kind of hand wave it away. And so they kind of had to take this registry that was mostly used for tracking childhood vaccinations and co-opt it to now tracking large-scale vaccinations where also you needed to track it and whether the patient consented or not. And so you kind of had to change this system, and that was very difficult. And so there were several publications reporting on this. The Laredo Morning Times reported that Laredo Health Director Richard Chamberlain noted that oftentimes people or providers would input people into the system, so 300 new persons, and then they would go back and those 300 people wouldn't be there. The Texas Tribune also reported that the Department of State Health Services spokeswoman said that they were aware ahead of time that there were going to be data issues, and they were working their hardest to train new people, new providers on how to work with the system, but you're just trying to train a lot of people in an emergency situation, and so there's always going to be issues with that. In addition, you had, like I said, a lot of people who were inexperienced, but also you're handling a lot more data as well. So they did their best to translate the system onto new servers to handle that massive shift in data. But as we saw with Laredo, a lot of times that data wasn't being saved properly. And finally, Nora Belcher, who's the executive director of the Texas eHealth Alliance, noted that a lot of these systems, they're not produced by the state. They're contracted out to companies who produce these sorts of software systems for states elsewhere. And so they don't necessarily design their systems to deal with this opt-in situation in Texas. It kind of has to be adjusted, it has to be changed, and then, like I said, it had to be switched back for the COVID vaccines. And so you're dealing with a lot of software changes that aren't necessarily ideal for the situation. So what did we see with the data that was available? So like I said, we were missing a lot of data, but we went ahead and looked at what data was available anyway. And what we found was that there's a lot of disparities in both white and black and white and Hispanic resident vaccination rates. So within white and black resident rates, white residents were found to be 1.65 times more likely to receive a dose of at least one dose of the vaccine compared to black residents statewide. And so it's about a 65% increase, right? And in several counties, you can see that rate actually superseded 3 to 5 times more likely. And when we're comparing now white and Hispanic residents as well, on average, white residents were 1.4 times more likely, so a 40% increase to receive at least one dose compared to Hispanic residents. And in particular, you can see a bit worrisome that in the high Hispanic regions down in the valley, that rate actually tended to be highest there. And in this case, I want to point out too that there's some discussions on non-white Hispanic versus white Hispanic and race and ethnicity. In this case, we just relied on the classifications used by the state health department. So some possible explanations as to why these disparities were there. First off, we could just say the disparities were there, and that's why that was reflected in this data, and whether that was due to access reasons, certain things like that, it's hard to say. In smaller populations, though, it may also be that a higher number of citizens in the unknown category will have a greater effect. And so if members of non-white groups were more likely to get the vaccines earlier when race data wasn't being recorded, or were more likely to leave racial information blank, that would affect the data that we're seeing, because we're only looking at confirmed race patients here. In addition, there was no information available to us on if recipients were residents of the county they received the vaccine in. So if they left the county to receive a vaccine, that data would be shifted over. And it's also, what we do think is unlikely is that this was due to different rates of vaccine hesitancy in racial groups. We found that it was a 40% amongst Hispanics and a 65% amongst Black residents compared to white residents in differences. There were some surveys before the rollout that showed slight differences amongst racial groups in willingness to get the vaccine, but not to the degree that we saw in the data. So we don't think that that was one of the causes. So yeah, I want to clarify as well that this, like we said, this data wasn't complete, right? We were missing a lot of the race data. So these disparities that we're seeing aren't necessarily there to the extent that we're seeing them. This is more of an explanation of what the data is showing. And so the data shows enough disparities that we should be concerned and we should want complete data. But really the main focus here is on ensuring that we do get complete data moving forward. So some legislative solutions to these issues. So in the last legislative cycle, so 2021, Texas Senate Bill 1353 was passed. That was sponsored by Senator Boris Miles primarily from here in Houston, as well as Senators Lucio and Seliger and Representative Guerra. So Senator Miles did a really great job shepherding that through the cycle and getting it signed into law in June 2021. So what Bill 1353 did is that it requires the state health department to include an assessment of racial disparities in vaccine access, economic analysis on the benefits of reducing those disparities, and recommendations on reducing disparities and increasing immunization rates in general. Now, one thing to note, and it got pushed off the slide here, but there was an amendment added that noted that this would only be done if a public health emergency was declared in the prior 2 years. And as we noted, a lot of these issues came about because a lot of providers were unfamiliar with the system. The vaccine system was sort of hurriedly co-opted into place. And so by requiring that some sort of health emergency is going on before doing this kind of hamstrings the bill a bit. We kind of want our State Department to be, familiar with this sorts of analysis. We want our providers to be familiar. We want this to be a sort of routine system so that we can make sure that we're getting all of the data available. In addition, another possible change we can make is to change the immunization registry, the MTRAC2, from that opt-in system to an opt-out system. So this was something that was sponsored by Representative Donna Howard, as well as Senator Zaffirini and Seliger again. And Senator Seliger is retiring, unfortunately, but he's been a great stalwart for the vaccine movement from the Republican Party. And this bill, it failed to pass, and it's been put up by Representative Howard multiple times. She's been great about it. But it failed to pass in 2015, 2017, and 2021, unfortunately. But she did manage to pass it way back in 2013, and it unfortunately was never voted on in the Senate. So what this bill would do is essentially it would mandate that the vaccination records be included within that DSHS-run registry unless indicated otherwise by the individual or the guardian in the case of childhood vaccines by opting out. So currently only those who enroll in the system are included in the system opting in. So there's really a barrier to being included. You have to fill out some paperwork. And what ends up happening is that about 80% of people who vaccinate their children don't really care either way. 10% definitely opt in and want to be included, and 10% would opt out if needed, and 80% don't really mind. And so the idea here is that we want to be including as much as possible. And so patients who are apathetic to the idea should ideally be included to empower our state resources with as much data and information as possible so that they can do their best job in keeping us all safe and healthy. Another nice thing is that it lowers the healthcare costs, since the group wishing to be included outweighs those who would wish to be excluded. And so you don't have to keep asking people, do you want to be in? Yes, take this form. Doing that, it's a lot simpler to just say, do you want to be left out? And a smaller portion of the population will then go through that paperwork. It also develops a much more robust vaccination registry because it creates a bigger system. It creates a system that's ready to handle lots of vaccination data that's just being immediately entered in. And so it creates, a system that's ready for the next pandemic if that were to happen. And so, so overall, this is just really about creating a more robust system and empowering our State Department to do its best. Just to kind of conclude here, the lack of information available when it came to race data really made it impossible for state officials to determine if inequities existed. So if they did exist, then this magnifies that inequity because it hamstrings our officials from being able to prohibit or to have targeted solutions. Again, this was largely due to hurriedly co-opting that smaller pre-existing data structure that many healthcare workers were unfamiliar with. And so developing Texas's current immunization registry into an opt-out system would better prepare Texas for future emergencies. It also saves money, and it still does allow for people to opt out, and it's interesting because we mentioned a lot of vaccine hesitant individuals during the course of the symposium today, but actually, they're never going to be asked to be included in a registry if they're not vaccinating their children. So this is actually an issue that's only related to people who are vaccinating their children. And it's really just all about empowering the Department of State Health Services. We had a lot of great people doing a great job with that, but they were kind of working with a broken system. And so it was really just about changing our system, strengthening it, so when those experts are once again faced with an issue like this, they'll be have the tools to be much more successful. So, thank you.
The lack of data that Mr. Navarro highlighted was put on a magnified glass during COVID, and we had to rely actually on data from other countries for all sorts of reasons because we don't collect data for race, but so many other things. As a reminder, if you have any questions for the panelists, Dr. Matthews, Dr. Navarro, please use the QR code on the agenda, the one on the right. It will take you to the Google form where you can point to the session and type in your question. Our third presenter this morning is Dr. Heidi Russell. Dr. Russell is a professor in management policy and community health at the University of Texas Health Science Center at Houston School of Public Health. Dr. Russell worked as a medical doctor of pediatric hematology and oncology before returning to school to earn a PhD in public health with concentration in health economics and health services research. Her research focuses on the cost and inefficiencies of medical care for children. In addition, she aims to improve the system for patients receiving care. She has conducted a cost analysis to measure medical costs and public health response costs to the Texas state budget as a function of child vaccination rate. Changes in policy results in economic consequences, and vaccine policy is no exception. If vaccine mandates are limited, the likelihood of vaccine-preventable diseases will increase. As learned through the course of the COVID-19 outbreak, outbreaks can have substantial economic consequences. Dr. Russell will be presenting on her research on economic impact of vaccines in Texas. Welcome, Dr. Russell.
Thank you so much for that kind introduction and for having me today at this symposium. I'm very excited to be here and have been quite thrilled with the discussions that we've had so far, and I'm looking forward to our public discussions after my presentation and fielding questions. Hopefully that will be nice. I'm here actually to talk about, as was introduced, I'm here to talk about the potential cost impacts of outbreaks as we entertain these policies that have the potential to lower vaccination rates. Then we have to be thinking as well about the potential consequences of those. And I'm thinking of it in particularly around the financial and economic impacts of relaxing policies. I've focused this talk on the state of Texas and implications to the state of Texas, although the things that we're going to talk about certainly apply to other states of the United States as well as other countries. Let me see, how do I change it? Oh, here we go. Wait. There. So this conversation is occurring 2.5 years after the introduction of the COVID pandemic, which, as we all are kind of experiencing at this time, we're living through a fairly significant economic change because of the COVID pandemic. Now, I'm not talking about the costs associated with the COVID vaccine. I'm more interested in the costs and the economic impact, the changes that occurred because of the outbreak of the disease itself. So, and again, there are lots of policies that can be debated and discussed, but basically, as a significant disease was crossing our country and we were experiencing loss of life, we resorted by necessity to one of the oldest kind of measures to slow down a contagious disease, which is social isolation. Quarantine and social isolation has been going on since we've known about communicable diseases. But that did have an impact on our ability across communities to earn a living and to participate in economic commerce. So now we're seeing that 2.5 years later, and we will be experiencing inflation and potentially recession for the next several years to come. So I take that as not necessarily that we need to be focused on the economic impacts of COVID, but that we have the opportunity to learn from that as we go forward and looking at other potential outbreaks. What can we learn from COVID outbreaks and the economic impacts that we can take forward as we discuss policies that might change our vaccination policy, or that might lower our vaccination rates? I'm having technical problems here. Wait, let's see. Oh, so I'm actually mostly looking at the childhood preventable illnesses, the things like measles, mumps, rubella, polio, the things that we have been vaccinating children against for the past 50 or so years. These diseases back in the 1950s and 60s were regular routine illnesses in our spectrum of social consciousness. So you pretty much knew someone who had one of these diseases or a child who had one of these if you were a parent at that time. When we introduced these vaccinations as a routine part of child care, we started eliminating those diseases from our public consciousness. And now we experience them not as sort of like a routine disease that most children get or someone we know is exposed to, but we experience them as outbreaks. And so in small communities where there are cases where cases did not exist before. And of course, we all know that there have been outbreaks of measles. There was actually a case of polio reported last month in New York, and there are outbreaks of mumps on a kind of regular basis. And other diseases have these as well. So that's how we experience them. We've talked a little bit earlier today, and a lot of the conversation around vaccinations, especially in childhood, kind of focuses on the individual's choice of getting vaccinated or not getting vaccinated. And so are the cost models. So when we talk about economic modeling or we talk about estimating potential costs of making a decision, many of the vaccination policies or cost models are kind of focused on this time frame on the left-hand side of the screen, when we were introducing vaccinations, or in the current day, if we are trying to enhance immunizations in countries or locations where vaccination rates are low. That is somewhat of a different model and concept than what we have in our current society, where we are able to vaccinate most people, or most children, against vaccine preventable diseases. We have the infrastructure, we have the vaccines available, we have a system in which that can be done. So we have to kind of change these models. We also have to step a little bit away in this conversation from the idea of the individual and start talking about a little bit the cost to the society. The way that we have been able to get such an awesome high rate of vaccines in the United States is by tying our childhood participation in government-funded education to having proof of adequate immune status. So when you go to register your child for kindergarten, or if you want your child to participate in a approved daycare setting, something that is state regulated, then you have to demonstrate that your child has had vaccinations that are appropriate for their age. This is the CDC's recommendations around childhood vaccinations from birth until until they're 18 years old. And you can assume the line is pointing to kindergarten enrollment. So children need to have most of the things that are, it's yellow in the actual picture and it's kind of like a olive green on this picture, but they should have had the doses that are associated with the olive green color. And then, so when they go to enroll for school, they have to demonstrate proof of those vaccinations. Now that's the regulation. Of course, there are exclusions or opportunities to sidestep that regulation. Some of that is because of medical indications, as we've talked about before, and some of those have to do with the ability to opt out because of either religious or philosophic reasons. To the extent that the local community or the state requires or makes that exemption easy, so the easier they make that exemption to get, the lower the vaccine rate of that community. I mean, that's been demonstrated time and time again. So when we're talking about sort of this concept that if we have policies that relax our vaccine requirements, that make it so that children don't have to have these vaccines, or that make it easier for children to not have vaccines prior to going to school, we will have lower vaccination rates. If we have lower vaccination rates, we will have higher likelihoods of outbreaks of communicable diseases. People continue to travel to places where these diseases are endemic, and they bring the diseases back into the communities that have lower vaccination rates. We know that COVID-19 had a significant impact on our global economy, and we need to learn what it was about that actually had such a significant impact and take that forward. But we also need to be studying this now, the potential for what happens if we have an outbreak of a preventable disease, in the context of COVID left us with a kind of a financial crisis. So we don't have a tremendous amount of financial buffer to manage a large, costly outbreak of a preventable disease. So to look at that, to start trying to model, to ask what would an outbreak actually cost if we allowed our vaccine rates to lower, I started to play around with a model that would estimate these costs in measles. Why measles? Well, it's the most contagious of the childhood preventable diseases, so it's really one that we have a lot of history of outbreaks in. So we have data to kind of build a model around it. We also have, it's kind of like the bellwether of vaccines. So because it's hit a lot of anti-vaccine rhetoric, people have this sort of perception about the MMR vaccine. But it also kind of coincides with other vaccines. So if people aren't are hesitant to the MMR, they also tend to be hesitant to the other vaccines that are given at the same time. So if we can build a model that represents measles, we can modify that model to represent other communicable diseases. Fortunately, or unfortunately, there have been cases of outbreaks that have been nicely costed out, so we can use data from other outbreaks in the United States and across the world to say, what are probabilities and costs associated with those outbreaks. The nicest of these is done by a group from 2019, and it was published in Pediatrics last year, where there was an outbreak in Clark County, Washington, which is just north of Portland, and they have a slightly lower than national average vaccine rate in that county. So when one of their community members traveled to another country and brought back measles, there was a subsequent outbreak of 71 cases over 4 months. Most of those cases were in children under 10 years of age, so that allows us to continue to focus on the pediatric population. So they estimated the cost of the public health response, the cost to be about $2.3 million to manage to contain this disease to those 71 cases. So that included public health tracking, that included things like enforcing isolation and testing for people who've been exposed to the measles. They estimated about $1 million of loss of salary and opportunity costs, and there was approximately $75,000 of direct medical costs. So from there you can see that the public health response and the loss of salary and economic commerce was greater than the medical costs specifically. So if we take those, I put this picture up to remind us how difficult it is to actually estimate the cost of anything when we're talking about something that has to do with the medical world and to do with the state and to do with commerce. Because this decision to vaccinate or not vaccinate or do anything that has any kind of repercussion on another part of the world, well, let me back that up. We don't live alone. Our decisions impact our community. We might want to not have that, but it is true. So the person making the vaccine or making the decision to vaccinate their child lives within a community that has decided or not decided to vaccinate their children or in their community. So they live in this sort of community of people. And that community survives on an economic commerce. They survive on the share and exchange of goods and services and monetary units. And in order to be robust, they have to be able to interact with that community. Whenever a child or a person needs a medical service, they are intersecting with the medical delivery system, which delivers a good that requires people to do so, supply, rooms, all of that kind of stuff, and there is a cost associated with medical services. Some of the cost of medical services for children are paid for by the state, and some are paid for by commercial third-party payers and employers. So it is really complicated to say. So in this particular setting, I am only looking at the costs of that might be incurred by the state in the event of an outbreak. That's the first step of this modeling, and we can include other costs in further stages. So I'm only looking at the public health response costs, so those things to contain the disease, and the costs of direct medical care for children who might be insured under Medicaid or the Children's Health Insurance Program. And I included in this the costs of children who do not currently have insurance because they would be sort of indirectly paid for by the state. It's a little complicated and it's beyond the scope of this conversation, but just say that a little over half of the children are included in the direct medical costs here. So if we look at measles, mumps, and rubella vaccine, there's 2 doses prior to kindergarten. The first one is given between 12 and 18 months of age, and the second is between 4 and 6 years of age, so around the time that children are supposed to go to kindergarten. There are some now public reports of per elementary school vaccinations. They're kind of hidden, but you can find them in the Department of State Health Services. But what this big orange blob graph demonstrates is that most elementary schools are able to vaccinate or have a very high compliance of the vaccines. But as you get towards the left, you see that curve drop off. That curve is actually representative of schools that have lower vaccine rates, and the lowest vaccine rate is 33%. I won't name this school. So I used the data from that, the data from the various publications of outbreaks to build what is called a decision tree, or we'll just call it a decision tree. And basically what it does is it allows us to estimate the costs over a population based on the probabilities that events happen and the costs of those events happening, and compare one scenario to another scenario. So I'm using the Texas population of children under 17 based on their age distribution, so when they would be getting vaccinated, and and who is actually covered under a state-funded third-party payer. Then on the top part of this, the kind of base case, the best case scenario is that 97% of children, which was the rate prior to the COVID pandemic, 97% of children have 2 MMRs by the time they hit kindergarten. Then there is a probability that they will be exposed to measles, which we can range over a variety of situations from anywhere from not having any measles in the community to an outbreak that would exist in a low vaccinated country. And then if a person is exposed to measles, there is a probability that they will contract measles, which is related to the number of doses of MMRs that they've had prior to exposure. If they actually contract measles, there is a 20% chance that they will go into the hospital and require care, and there's an 80% chance that they won't. There is also a low probability that they will die from the measles or have a long-term consequence that requires continuous medical care. I did not include that in this model because I'm looking at the very short costs of an outbreak. We can include these longer term costs later on. So that's the top line. The bottom line, the probabilities are basically all the same and the costs are the same, but we can vary the rate and compare the costs at a 97% rate of vaccination with a variety of costs of vaccinations as the vaccination rates lower. Yeah, so what this gives us is a weighted average. It's kind of complicated to picture in your head, so let me just say that it is a weighted average of cost per child across a population that can then be scaled across the size of the population. So what the kind of results of this first phases of this model look like are on the left-hand side is the average state medical costs per child, and the right is the average public health response costs per child. Along the x-axis of both of these, along this bottom line, is the probability of exposure to a patient with, or a person with case of measles. So we varied that from Texas on a good year, all the way up to case numbers of high outbreak numbers in countries with low vaccine rates. And then the different curves represent the vaccine rates across that population. What is really apparent is that as you experience more probability that there's going to be measles, the costs of those outbreaks on the average cost per child start increasing. We see an inflection point in those curves at around the place where you get 1 case per 2,000 children, which is, by the way, approximately what the case rate was in the Washington outbreak. And then as you get more cases, the costs go up. What is interesting is those curves are kind of similar for both the medical costs and the public health response costs, but the y-axis, which is along the side, ranges from $0 to $9 on average cost per child for direct medical costs. But it goes almost up to $60 for public health response costs. So costs of containment, costs of tracking public response is higher than the direct medical costs. I don't want us to walk away from this saying, oh my goodness, we're spending too much money on containment. That's the wrong message here. Because we're just looking at the types of buckets of costs that an outbreak would impact, that might impact the Texas state budget. We have grossly underestimated the costs of medical care for children with measles because we have not included the costs associated with children, the other half of children who are funded under commercial payers, right? So we're only looking at half the cost. And then you might say, well, gosh, $60, that just doesn't seem like that much. The state can cover $60. That's an average cost of $60 per child across a community. So to put that in a little bit of perspective, if we were to say lower the Harris County rate of vaccinations from 97% down to about 80%, which is conceivable if we were able to, if we relaxed vaccine requirements, and there were an outbreak of measles in the city of Houston, that's 1.2 million children. And that would, at an average cost of, somewhere between $20 and $30. The difference between having a 97% vaccination rate and having an 80% vaccination rate is about $8 million to the cost to the budget of Harris County. So these, when scaled, these per average costs are quite meaningful. I've only discussed so in conclusion, as immunization rates decline, the cost of an outbreak associated with that vaccine preventable disease will increase. From the perspective of the state budget, containment is more expensive than, or is a greater cost than the cost of medical care. But that we've grossly underestimated the costs here because we're only talking about measles, not mumps, rubella, not polio, not any of the other diseases. This is just an opportunity for us to develop a model on which these other things can also be built. And we also only included the state budget. We did not include things like loss of salary, loss of economic impact to the individual or the community. We did not discuss loss of commerce, or impacts on the medical system. So this is a very small component just to kind of check proof of principle. But I think in the current state where we are facing a larger global economic challenge, we really need to be thinking beyond the individual choice of having vaccines, but also being prepared for what happens if we do have an outbreak in our current state, and what those policy changes will have on the budget as a whole. So I particularly want to thank Dr. Matthews and Jackie Klotz for hearing me discuss this model ad nauseum, and to the Baker Institute staff and the Vaccine Project, on everybody that's here to have this, to be with us today. Thank you.
Thank you so much, Dr. Russell and Dr. Matthews and Mr. Navarra. So I will invite you now to the podium, and we will begin the Q&A session. Please remember to use the QR code on the back of your agenda on the right to submit the questions using Google Docs.
Do you want to ask each other questions? I want to ask Adam a question while we're waiting. I liked the presentation, and I really appreciated the discussion about the MTRACT. And you mentioned that we're an opt-in system. So how difficult would it be to switch to an opt-out? Would it require a lot of paperwork, consent? For a user, how hard would it be?
Good question. So it would come first from a legislative side, right? So the legislature would would decide how much the state health department is able to collect that data. And it would probably, your difficulty from a user side, so it's primarily medical professionals who use the registry, right? So the people who have access to the registry are just medical professionals, doctors. And what they're doing with it is they're primarily, if a patient comes in and they want to see if their vaccinations are up to date or if they need any vaccines, they check the registry. So from a provider standpoint, probably doesn't change much. If anything, it just changes your procedure from going, we'd like to include your information in the registry, do you consent to that, to we would like to include your information in the registry, is that do you not want to do that? And so then you provide, right now, if they want to be included is when you provide the paperwork to collect that consent information. And if it were to switch to an opt-out system, then it's only if someone doesn't want to be included, that's when you provide the paperwork. So a few surveys have shown that the group of individuals who want to opt out is smaller than the group of individuals who want to opt in. And so it's actually probably less work from the provider's side. And a lot of immunizations are happening in infants as well, right? So I mean, when children are born, and you have young pediatric patients, and you're dealing with all that, it's a lot easier to just be like, we're going to collect this, we're going to have the state hold on to this information, is that okay with you? And if they're like, yes, then you just kind of keep going. So yeah, I think just given the difference in population size of who wants to be in and who wants to be out, it would be easier to make it so that you only have to consent to being out. Yeah.
The issue of completion of data is very important, and there are so many ramifications. I know your study focuses on race during the COVID-19 pandemic, but we are faced with it in clinical care all the time. You get a patient, I don't know, he used to live in Louisiana, he's in my clinic. Did you get your hepatitis B shot? I don't know. They don't know. I have no way of knowing except tracking their, their doctors that they used to take care of them. Sometimes they used to get their care in different locations. So it becomes almost impossible to provide good care for that patient except, well, I'll vaccinate them again. And the vaccines are safe, but probably they did not need it. So this is one example of how the fractured system of collecting data on vaccines from birth onwards is costing the system a lot in terms either of missed opportunity to vaccinate or additional vaccinations that were not probably required. It has many layers, and I am very pleased that your research is focusing on this question that has, again, many ramifications. So, questions from the audience to Dr. Matthews. The quotes you shared are eye-opening. During the testimony hearings, how did legislators typically respond to more extreme statements? I guess the audience is worried that the legislature will be swayed or...
That's a great question. So, well, I'm going to start with is I actually did pick really fun ones. So I'm going to be completely honest. We were going through them and we're like, wow. And we just paused when we saw the first two specifically. And then the third one, I wanted to pick one in particular to share with you where we could follow up on what they were quoting, because I didn't want to pull one where we couldn't verify whether or not the data was true or real or accurate. We also noticed how the legislators responded. Now, we do have to remember these are kind of their constituents, so they were extremely respectful. A few of them would kind of push a little and challenge, saying, you sure about some of the issues? Some of the ones I probably mentioned, they probably just kind of let slide. All right, thank you very much. But we did have a few legislators who were all in for the anti-vax rhetoric. They were pushing and promoting. I'm looking at Reka right off the stage, and she knows who we can name names, but I'm not going to at this moment, that were encouraging some of them to be even more kind of extremist. In addition, I'm going to mention too is there is part of this subject. It's not like we went randomly and pulled people who were part of the anti-vax. They got to hear each other, so there might be kind of an additive effect. Like as in when they all got collected together, each one would reference the other person, things they referenced, and maybe take it a step further. So it's almost like, oh, well, you said we need medical freedom. Well, I'm going to mention U.S. rights. You said U.S. rights. I'm going to say they're tyrants. So I can't actually say. It probably being in all together that it might have actually just kind of riled them up in more extreme. And these hearings lasted for like 5 hours. They just sat there and listened. By the end, I think the legislators were like, great, next person.
They don't time them?
You only get a small amount of time. You only get 3 minutes. But yeah. I think what was a total of almost 200 people, 15 hours, just slowly going through. Next person up. Go through. And then some of them were invited and had longer testimony. I will say the one I was most disappointed in is we had some doctors who went up there who testified against the COVID vaccine, and they brought in data that was just blatantly wrong. They said, oh, well, we didn't have a vaccine for H1N1. I'm like, yeah, we did. They would say statements like that, and I was very tempted to write them a letter. Hi, do you know these 5 points were completely wrong? I'm really disappointed in you. Mm-hmm. So, forgive my ignorance in the process, the legislative process, and maybe this is a question to Reka later. Do they allow, like, when at a national level, some laws have what they call bacon in it?
whereby you
yeah.
pass an important bill on which there was a lot of negotiations, a lot of bipartisan sort of back and forth, and they finally come to a compromise. And part of the compromise is parties insert their pet peeves in them.
I don't know if it's always agreed or not agreed. So yes, pork is something we say on the federal level.
Yes.
In Texas, Reka will always tell us about the conscientious objection was on a Christmas tree bill. So it was a bill they had to pass, and everyone threw in their favorite item in at the last minute, and they had to pass it, and that's how we ended up with it in 2003. So we do see that there perhaps is discussion whether or not the amendments are appropriate. I don't know if we see it a lot, but there are some times when they're pushing towards, I'm guessing it's probably was a budget bill, that the Christmas tree was a bill specifically that she referred to. But most of them I don't know. There's little things. Reka will give you more details about that. Mm-hmm.
Very good. Question to Dr. Russell. Given your projection discussed, where do you see this impacting policy to build upon the work you're doing? I think we all think we have time to think about this, but as we can see, with concepts of infection and globalization, we may not have as much time to think.
So I'm assuming they're not meaning my personal time, but we're talking about the time of sort of what's happening in the world. I think we have, when we're making policy decisions, it's important, I think, that we are not, we take the individual as part of the conversation. We need to do due diligence on the impact to the larger society, the larger community of these decisions, especially in diseases or in events where the impact is real. So as these conversations are going, I think that we need to be having a voice that says, well, it's not just about this one thing, and while I accept that that one thing is quite important, we need to be looking at the costs of our medical decisions. That's true not only in vaccines, it's true in across the whole healthcare industry and the sorts of decisions that we make about what is best to do under any medical conditions, right? We do very little discussion about the costs of those decisions. So, but right now, when we're facing sort of an economic challenge at a global level, and we're facing an opportunity to potentially make things worse by relaxing vaccine policies, we should be having that conversation. The cost of those outbreaks should be on the table, and do we have the capacity to manage that if that were to happen? So I don't know exactly who and where and how, but that needs to be as part of the conversation, not just the individual right, but and not just the health of the community, but the economics of the community. Because I think that's even a broader impact than health.
For example, the New York measles outbreak was larger than the Washington state outbreak.
Yes.
And it led to a lot of economic and financial fallout.
Yes.
Was that part of the model, or sort of the factors you used in the models?
I took whatever, so I only presented the publication that was from pediatrics, but I did include data from other, if they have published the data from other models or from other outbreaks, I've included that. There's also some data from Canada on the costs of the public health responses. So this has actually that has been a topic, and it's well established that these outbreaks are costly, but it's not really being paid attention. We're not paying much attention to it as we're talking about vaccine policy changes. Yeah.
Excellent. So question to Mr. Navarra. You have two questions. I'm going to combine them in one.
Okay.
You alluded to one already. Does the fact that the Texas vaccine registration system is opt-in lead to bias in the data in terms of who opts in? And the second question is, have you considered exploring the cost-benefit analysis of other states' opt-in systems? This may highlight the Texas need to switch their model.
Yes, so it's an interesting question about, the bias in the registry. If I were to theorize, I mean, I would think that if you were to kind of track trust in public institutions as a metric, you are certainly going to have more people who have a higher public trust included in the registry compared to not. And when we think about the importance of the registry, it's like I mentioned sort of during my talk, it's a public health tool, right? We're trying to provide our state health department, which is mandated to keep us all healthy and safe in the state, to do their best to track these sorts of breakouts and these sorts of diseases, and where they may need to target certain quarantine things, or if they're just trying to increase vaccination rates in certain regions. And so if you're missing data from groups who may not necessarily have a high public trust, even if they're vaccinated, if they have, if there's some sort of difference between having a medical trust versus a public institution trust, then that's kind of where you're starting to lose that insight. So maybe, and I think, the main issue with the registry is just trying to keep as much information in it as possible, so that the department is empowered as much as possible to do what it's designed to do. And with the cost benefits, the paper we sort of looked at that assessed Texas also looked at other states as well. And they, essentially what they found is that most of the costs of the immunization registry gets tied up in just sort of the accessory costs of taking up healthcare providers' times to prepare paperwork. It's largely pediatric nurses who are in charge with organizing these and getting them all signed and making sure all the information is properly filled out and filing it away, entering it into the system. And so being able to skip over that process, because a larger portion of the population wants it to happen, but doesn't necessarily need to go through all of that red tape to get it done. That's largely where the costs come into play. Yep.
Well, you would think with the electronic data systems, a lot of the effort would be decreased and streamlined. So even the cost of many of the methods we use to track these individuals or our individual vaccine records, etc., can be made on the cheap, quote unquote. But so I don't know. The question to it's the end of the session, I was told. There was one question to Dr. Matthews. I guess we'll just.
Ask it. I can answer really quick. So what's the question?
They erased it. Okay. I'm going to try and remember. Should we vaccine advocates, people who are vaccine advocates, should they start planning to go to these sessions and speak?
Absolutely. Yes, we need more people who are speaking for the majority to come and participate in these sessions. Rekha and I would be happy to share information and put together a network if you need more. The unfortunate part is that the hearings, I think you get a week notice, it's really short and you have to turn around really quickly. But the number of people, and there has been a really good group, especially when they start seeing these bills coming up, that comes and tries different physicians that are able to participate them. And we did find that as well within the hearings and within the witnesses, that we saw a lot of people who were supportive of vaccines as well. And definitely we need to make sure that our state legislators understand that that is not the majority. Having that one person come every single time isn't 5 voices, it's 1. So we also need to share our voices in this.
All right, very good, thank you. Well, thank you so much, Drs. Russell, Dr. Matthew, and Mr. Navarro. We have a 10 minutes break before panel 2. Thank you all.